resources already flows from the African diaspora to families and communities across the continent. So the question we want to explore today is, how do we create the trust, governance, and investment structures that can unlock more of that capital for healthcare? So we're going to keep this very practical. We will drive the conversation using 3 key themes. What is holding us back? Secondly, what is already working? And third, and most importantly, what needs to happen next? And so before we get into the conversation, just a couple of housekeeping notes. If you have any questions, please drop them in the chat box as we go along. We will come to those questions during the Q&A segment at the end of the panel discussions. Immediately after the discussions, we will also have an open mic segment. We know that there are so many experts and practitioners in the room, so we want to create some space for your reflections, comments, and perspectives before we close. So with that, let me introduce our distinguished panelists. Let me start with Ambassador Amr Aljowaily. He is the director of the Directorate of Citizens and Diaspora Organizations at the African Union Commission. Ambassador Aljowaily brings the continental policy and institutional perspective to our discussions, particularly around how Africa engages its diaspora. Ambassador, welcome. But before we get into the main questions, in a minute or so, when you think about unlocking diaspora capital for Africa's health sector, what is the first opportunity or challenge that comes to mind?
Thank you very much, Madam Moderator, and allow me to start by thanking Africa CDC as well as the Catalyst Forum for this opportunity, and especially that we know that it's going to be a sustained dialogue. This is only the first of a series. We are very appreciative of the growing partnership with the Africa CDC on health and diaspora, because we believe, of course, that health is a priority sector for Africa, and diaspora is a high potential for the continent. So marrying or wedding the two is very much a priority for us. You asked about the opportunity and the challenge. I would say that the opportunity is that already remittances are playing an important role in Africa's development at the household maybe level. We know the level of support that African diaspora provide to their homeland through household income support. So that's an opportunity, because it really shows that capital is already moving at a scale and already trusted enough to send. In fact, as you would, your concept note mentions, we're talking about $100 billion and above for 2024. However, the challenge is that we need to move from the first gear to the second gear. We need to transform that household income support to an investable channel. We need to treat diaspora health professionals not only as remitters and occasional volunteers, but as investors and co-designers. And that is the next phase that we need to move to. And I'm very glad that maybe an avant-garde of that transformational change is the health sector through this growing partnership. So we are very much on the same line here. That's the opportunity and the challenge.
Thank you, Ambassador. And I think that there are already a few themes there that we will certainly come back to. Next, let me welcome Mr. Nicolas Bassey. He's the Chief Operations and Programs Officer at the African Diaspora Network. Nicolas works closely with diaspora communities and brings an important perspective on what actually drives diaspora engagement, from goodwill and connection to investment and actions. Nicolas, welcome. From where you sit, what is the one thing we need to understand about the diaspora if we genuinely want to move from remittances towards investments?
Well, like the ambassador, I thank you greatly for the opportunity to join in this important conversation. Um, the answer to your question, I think, is there are many nuanced responses to it. I think it is the central question for us, recognizing that remittances and investments are they're not different amounts of the same thing. They are different things entirely. So from our view, remittance is an obligation to family. You send it because someone you know or someone you love needs it. You don't ask for a return. Philanthropy is generosity toward a cause. It feels good. It's values driven, but it's a one-way gift. Investment is different. It asks someone to trust a structure they can't see. It's run by people they usually can't check up on in person. It's going toward an outcome that isn't guaranteed and sometimes isn't initially visible. So the shift that we're talking about isn't convincing people that they have money. People know that, given how much money they're sending every year. It's about closing a trust gap. And as we proceed in the conversation, I'm glad to expound a bit more on some of the three items that I think would help to enhance trust, improve communication, and make the environment where investment rather than remittances can thrive.
Thank you, Nicholas. And I think that distinction between the diaspora interest and actual investment is going to be important for today's conversation. So next, and finally, Dr. Serge-Alain Wandji, co-founder, president, and CEO of DiaspoCare. Serge brings the operator and innovation perspective, having built a platform specifically addressing how diaspora resources can connect more directly to healthcare needs. Serge, welcome. As someone who has tried to solve this problem from the market side, what have you learned about what it takes to build trust around diaspora-funded healthcare?
Thank you very much, Bawo, and thank you to the Health Catalyst and Africa CDC for organizing this session and giving us the opportunity to share our perspective on how do we convert remittances into investable, health instruments. So from our perspective, when we started DiaspoCare, we knew one thing. And as diaspora members ourselves, is that it wasn't a lack of willingness to finance healthcare, right? Because we all finance healthcare every day, right? We send money for medicine, for consultation, we pay for hospitalizations and emergencies. The problem is we don't know how the funds that we send for healthcare are utilized. So we don't know if the money that we send for medicine actually purchases medicine. We don't know if the price that we were quoted is appropriate. And we don't even know at the end of the day if the care was received at all. So I think that in order to convert those remittances that are really moral obligations, like Nicholas was saying, into investable instruments, we need to not just ask for trust, right? We need to build trust. We don't just need to ask it, but we need to build it into every transaction so that there is transparency, traceability, so we know exactly how the funds are utilized. Being able to pay providers directly is really removing all the intermediaries, and it gives a sense of comfort. But at the end of the day, I think what matters the most, if we really want to change that behavior, is making sure that we have outcomes, that we have good health outcomes, that we have outcomes that are measurable. And that is a certain amount of governance and accountability that are in place. So I'm happy to elaborate more later.
Thank you, Serge. So already we have three interesting perspectives, the policy institutional lens, the diaspora engagement lens, and the healthcare operator lens. So we'll build on those initial thoughts and get into our first round of discussions. with the theme, what is actually holding us back? So Ambassador, let's start with you. So Ambassador, every continental framework, the AHSS agenda, the Accra Reset, Africa CDC's financing strategy, agrees that diaspora capital should move beyond remittances into structured investments. Yet none has made it operational. Now, from inside the African Union's own diaspora directorate, what is actually standing in the way? Trust, regulation, or something else entirely?
Indeed, there is something holding us away, and that is the reason for which we all put our hands together and our minds together at this stage to be able to overcome those challenges. You mentioned one of the three. I would probably say it's the three together. Trust, diaspora savers, they haven't always seen a credible, transparent vehicle, and so that they can actually engage in and with. Regulation is also another challenge because we see that there are different sets of regulations across the continent, and then still operationalization is one that that is also a challenge. You did mention, or maybe in our earlier discussions, the African Diaspora Finance Corporation, which has been endorsed conceptually when it was presented 2021 and I believe in the 2022 Executive Council decision. However, that has not really left the ground fully. So we have part of the frameworks, as I was saying, conceptually, the African Development the African Finance Development Corporation on diaspora is there, but we haven't translated that framework into an instrument yet. I've only been in my position for a year, and I can assure you, both the speakers and all the distinguished audience, that this is a priority for us at the moment. We are of course, you know, the decision making at the African Union level is multi-tiered. There are the intergovernmental mechanisms, such as these, what we call the specialized technical committees, which is basically ministerial meetings. So in this case, it will be the ministers of finance. They had endorsed the concept, but then they had asked for additional feasibility studies and more detailed operational directives, which is one of the priorities for 2027, to really elaborate on that, hopefully to get another gavel and approval, and that would set the mechanism going. So we need to transform from frameworks to instruments, because at the end of the day, the diaspora would need instruments to engage with, to buy in order to direct their finance into the health sector as a public investment.
Great. Thank you, Ambassador. And maybe just to probe a little bit further before we move into the next question, how would you rank the barriers? Really, so what will come? You mentioned the framework, you mentioned trust. If you were to rank it, how would you rank the gaps that you've seen?
Thank you, Mama, for that additional question, and it allows me to actually pick up on where I left. One thing that I have discovered since I've joined, and once again, I'm relatively new to this community, is that the scale is a challenge. Africa is 1.4 billion people. It's a huge continent. It's a really, solid, integral component of the world population. 1.4 billion people. Diaspora is between 200 and 300 billion, depending on the definition of diaspora that you assume. Now, if you try to match diaspora as a whole with Africa as a whole, it is so ambitious, but also it makes it very difficult operationally. What we are trying to do now, and I hope through you and through this distinguished community, is to scale down on two dimensions. Scale down on the geographic level and scale down on the thematic level. So when we speak about health, that's already a huge step forward, because we are limiting, not limiting, we are focusing our effort on a sector that is a priority for Africa. Maybe also we scale down geographically and we choose one of the RECs, the regional economic communities, for example, and then we focus on that health sector with that region as a pilot. I'm not saying this should be our full ambition. I'm just saying this can be our starting point. And I believe that if we do so, we will be able to have a concrete result that is contagious, to use medical terminology, contagious to other regions and to other sectors to catch up with.
Thank you, Ambassador. We'll move to Nicholas. Nicholas, the ADN works with diaspora members who already give generously through remittances and philanthropy. What does it actually take, in your experience, to shift someone from sending money home to investing in a structure?
Thank you, Bawo, for that question. I recognize that in my first comments, I didn't say anything about my organization. So if you'll allow me a little latitude, I need to be able to walk back into the office knowing that I represented our organization well. So I'll spend just a moment on that, and then I will come to my answer to your excellent question. So the African Diaspora Network convenes Africans from the continent, descendants of Africa, including African Americans and Afro-Caribbeans, as well as allies, to create an ecosystem that is designed to nurture entrepreneurial spirit and mobilize intellectual and financial resources for a prosperous future. We do that through strategic partnerships, through innovative programs, and we serve, our aim is to serve as a catalyst for positive change and growth in Africa, in the diaspora, and in global communities. Now, we know that last year marked the largest single year cut to official development assistance in history. It was almost 25% drop, driven in part by the dismantling of USAID, and Africa absorbed the sharpest cuts of any region. So now foundations and nonprofits and others are asking the same question: what fills that gap? What's clear to us is that the answer is not more aid. It's capital that already exists, but remains structurally underused. We know that the African diaspora sent over $1 billion to the continent just in 2024. That's more than twice what the official development assistance was for that same period. So capital exists, it's real, it's committed, it's flowing. What's missing, as the ambassador was saying, is the infrastructure to convert it from a household lifeline of sorts into structured, investable development capital, and then take that to scale. So the African Diaspora Network, or ADN, has spent the last 16 years building relationships, commitment, and a track record in hopes of closing that gap through direct entrepreneurship and innovative financing work on the ground. So the answer to your question, I was talking earlier about trust, and that there are three things that we think help to close that gap and promote trust. First is proof. So diasporans don't want a projection. We want to see that someone who looks like us, who is perhaps from the same town or the same church or the same WhatsApp group, has already put money into something and either got a return or made an impact, or just as important, got honest, regular reporting, even when things didn't go perfectly. So we know for our communities, trust travels through relationships. It doesn't travel through marketing. So a credible person that we know saying, I did this is what happened, here's what I would do differently, does more to move someone than the best slick pitch deck or return projection. So that's the first thing. The second thing is that we think that targets should be small at first. So no one moves from sending $200 a month to their mother to wiring $20,000 to a fund that they've never heard of. So that's too big a leap in dollar amount as well as in trust. So we believe that you need a small, well-defined entry point, something that lets the person's first commitment feel like a test that they can afford to lose a little bit, not a leap of faith that you can't afford to get wrong. So once that small first bet pays off, or is at least handled with integrity, the second one gets easier and then the size can grow. The third is that any structure has to answer questions that people might be too polite to ask out loud. So who controls the money? What happens if a partner mismanages it? Is it compliant with US tax law? Can I claim a deduction? So if these answers aren't crystal clear at the beginning, people will default back to what they already know works, and that's sending money directly to a relative or a trusted local contact, because that relationship is real and there's a level of accountability in there that doesn't exist in an unfamiliar structure. Now, all of these are the reasons why we built the African Diaspora Innovation Fund, which is a partnership between ADN and a group called Myriad USA, which is a registered US charity that administers donor-advised funds under strict regulatory oversight. That means that nobody's being asked to just trust our word alone, that there's an existing, an established fiduciary structure that has compliance and reporting behind it, and it's what you would expect from any serious financial institution. And so what our approach is, rather than asking someone to write a large kind of uncertain check to an entrepreneur they might have never met, whether that's in the health space or any other space, our goal through our fund is to pool diaspora giving into catalytic grants for early stage African and Afro-descendant entrepreneurs, really at the stage where capital is the hardest to find and it does the most to unlock anything that will come in healthcare and education, youth employment, climate resilience, whatever the area might be. And so this is a model that we think will work. And we have a couple of programs that feed into that entrepreneurship pipeline because we know that it's transparent, it's accountable, it's honest, and we believe that it is proof of concept for what a well-structured diaspora capital can do at the grassroots level. So I hope that responds to your question. I'm glad to respond to any follow-up you might have.
It does, yes. And a follow-up just on your last point, what do you think that diaspora is interested in? Is it the financial return, the social return, or both?
Yeah, I don't think it's a singular answer. I think there are some people who are most interested in a financial return, which is understandable. And there are people who are motivated by a social cause, and that is acceptable as well. People feel very strongly oftentimes about making a contribution to the place that is their reason for being. So I wouldn't say that it's one or the other. And so some structures will try to appeal to both, others would try to appeal to one versus the other. And so our structure, because it's a donor-advised fund, it is not focused on realizing returns for the investor. It's more a social, it's creating the opportunity for businesses to grow and for diaspora members to be part of that. So this is something that just started last year. We're capturing data on it. We'll be very interested to see how it grows, what we learn from it, and how we turn that into programs in the future as well.
Great, thank you, Nicholas. So shifting to you, Serge, you built DiaspoCare specifically because remittances meant for healthcare often don't arrive as intended. What does that gap tell us about the deeper relationship between diaspora communities and the institutions meant to receive their money? Is it a product problem or a trust problem?
Thank you, Bawo, for that question. But perhaps also before I answer, let me take a few seconds to introduce DiaspoCare. So what DiaspoCare actually is. So DiaspoCare is a US-based company that we started because we were frustrated by the lack of accountability when we were financing health, right? I mean, so you send the funds to support your family health, but you don't know if the fund actually are utilized for that intended purpose. And you know that it's not, right? Most of the time, there's a diversion of funds. So with the best intentions, you don't get the outcomes that you're looking for. So with that in mind, we decided to start this company. And really initially really what we wanted to do was just making sure that the remittances that are quite substantial already, but that are meant for healthcare are properly channeled for healthcare. So there's absolutely no diversions of funds. So that's really what the job number one was. But in the process, we discovered that it's actually a lot more complex problem, right? Because I mean, it's one thing to solve the end user funds challenge, but it's something else to address the other jobs that African diaspora members have, right? When it comes to taking care of family members from afar. So, for instance, you want to make sure that um, you understand exactly what's wrong with your mom. Well, she's been circling from doctor to doctor. She's taking 10 different prescriptions, and you never really get the gist of exactly what's going on with her. So being able to have that transparency of information is actually one of the jobs that's very critical for diaspora members. But the other thing too is who's actually really taking care of her, right? So is there a kind of a clear coordination? We've heard also of all kinds of issues, right? Counterfeit medication and so on and so on. So there's a lot of anxiety. Diaspora members don't sleep well when a family member is sick. It doesn't matter how much money you send, right? So we realized that the problem was a lot more complex than just ensuring that the funds are properly channeled to providers. The bigger job is understanding, right, having information available at any time. So I'm a diaspora member. I know exactly what's wrong with my mom, right? I know that the pharmacy that's close to where she is has her medication on a regular basis, which is one of the reasons why we really admire organizations like mPharma that have really built themselves on allowing the information to be available, right? Ensuring that medicine is available, ensuring that the care is available. So, so now, the other challenge too is, we know that infrastructure is a problem across Africa. And we also often heard that, we need to build more hospitals. It is good to build more hospitals, but however, we need to look at the size of the challenge. You have over 500 million Africans who don't have access to primary healthcare when they need it. So how many hospitals are you going to build actually? So it's not just a physical solution. So you need to be thinking about like other innovations. How do you actually reach those who don't have access to hospitals, who are in rural areas, for instance? How do you enable them to have access to care when they need it, right? And the appropriate care and at an affordable price? Because let's not forget, over 100 million people fall into extreme poverty every year because they cannot afford healthcare. Right? So making healthcare affordable, making it available, making it accessible, and the right care for the right issue, right? Those are some of the things that we need to be thinking, right, when we envision healthcare financing. So just to get back to the question, so I think it's both a trust problem and a product problem, right? However, I think that the product has to solve the trust problem. And what I mean by that is we can't just continually ask diaspora members to trust us with our innovation. We need to build trust into every transaction so that when I send the money, right, there's transparency, there's traceability, right? I know exactly where it goes. I know what the outcomes are, right? I know that is accountability. So with that minimum, requirements, now I can start thinking about, okay, all right, so we design trust into the system, right? Now, we can expect diaspora members to start, right, giving more money, or actually to cross from, that moral obligation of helping family members to actually an investable product. Thank you.
Thank you, Serge. And then I'll throw this question out to the panel, and any of the panelists can answer this question. No African diaspora bond issued to date has been health specific. They funded general infrastructure and budget deficits instead. Is that an accident of sequencing, or does health carry a different kind of risk than infrastructure? Anyone wants to take that question?
I can take a crack at it. So I think there's a challenge when it comes to healthcare as an investment compared to when you think about, generally understood and generally known, investment instruments. First of all, when you invest in infrastructure, right, you can see the road that is built. You can see the bridge, right, that your investment is financing. But when it comes to healthcare, it's a lot more diffuse, right? I was mentioning hospitals, for example, as a potential asset, right, in which people can invest. That sounds good, but given the size of the problem, how to build enough hospital to have 500 million people who need access to that. You need more than that. The other thing is you have a fragmentation, right? So a fragmentation problem when it comes to healthcare. So the challenge is also, how do we aggregate? How do you channel those funds? There's data, right? You have also the payment, the repayment, right? So if you invest into healthcare startup, for instance, that is catering to the challenges of the needy, and perhaps is banking on the National Health Insurance Program, right? Well, it's all good, but how fast do they get reimbursed? Because I've seen really good health innovators, right, invest their innovation and their time and energy, and even some investors investing in such right innovations. But at the end of the day, if they don't get reimbursed on time, right, they have a cash flow problem. If they have to wait for 6 months to get reimbursed, for the services that they are providing, there's no way they're going to hold. So when it comes to health innovation as investable instruments, compared to the traditional instruments, investment instrument that we think about, there are some challenges. Doesn't mean that cannot happen, but you need to have a more systemic. A lot of things need to come together, right, to be able to address the expectations of an investor.
Thank you, Serge. So we'll shift now into the second round of discussions. Let me pull this up. I'll just speed things up a little bit. So, Ambassador, I'll move to you. Beyond policy endorsements, right? What evidence do you see that structured diaspora investments is gaining real momentum?
Thank you, moderator. And just the mere fact that both Africa CDC and the Commission and all of you, because we all did meet after all in Grand Bassam, established that expert working group on health innovation and financing. I think this is one proof that we are moving towards this structured diaspora investment once again in a more focused way, because we're addressing the health sector in particular. I know, and I think my colleagues from Africa CDC would speak on that much better, Dr. Nadia and her team, that the Africa's CDC own financing strategy pilots these new revenue mechanisms, diaspora instruments, I believe, in 30 countries or so. So that already is an example of the structured form of investment. Now, with the African Diaspora Finance Corporation, I mentioned to you how it has been conceptually launched, but yet to be operative. But that doesn't mean that things have not been moving in that direction as well. I know that the author of that study did establish what I think is called Remitted, which is a remittance match funding mechanism. Loosely related to the AFDC, but still within it. So there are a few examples whereby we're moving into the structured investment, and as the dialogue continues and as the expertise gets pulled on, we'll probably progress further in that direction. But I have high hopes for this expert working group. I have high hope with the Health Economics and Financing Division of Africa CDC that it can further institutionalize that form of engagement.
Great. Thank you, Ambassador. So Nicholas, we'll move to you. What patterns do you see in which diaspora members convert interest into capital versus those who stay engaged but never quite commit?
Thank you. So I think the pattern has less to do with wealth or passion. Plenty of people who never convert are just as generous and just as connected to home as those who do. Because I tend to think in threes, I think that what separates them is usually one or more of these three things. So the first is whether someone has a personal translator for the risk, as I mentioned earlier. So the people who invest likely have someone in their life, friend, a cousin, a board member, someone they know who's already done it and can plainly explain what actually happens to the money that they invested or contributed. So the people who stay engaged but never commit are waiting, we think, for that same reassurance. So if no one in their circle has gone first, they will wait probably or maybe even for years. The second is how they were first asked. So if someone's first exposure to diaspora investing or making a diaspora-focused contribution is in a big kind of open-ended appeal, something like invest in Africa's future, that's very broad. They will nod, they'll stay on the mailing list, but they'll never act because there's no specific decision for them to make. So our premise is that the converters are ones who likely got a small but concrete ask. So that is, check out this entrepreneur, invest this amount, you're likely to get this outcome. And so specificity helps to turn interest into a decision. The generality, conversely, lets people stay comfortably interested but inactive for an extended period of time or forever. The third is whether the individual's identity is tied to being a builder or a supporter. And there's nothing wrong with one approach versus another. Some diasporans see themselves as stewards of what already exists back home. So they're protecting families, sustaining community, things like that. Others see themselves as builders of what's next. So the engaged but never actually committed group is disproportionately in that first bucket. They're not necessarily reluctant, they're just oriented toward preservation instead of creation. We think that when you can show a builder-minded person a concrete project with a name, with a face attached to it, with some references, something like what I was talking about earlier with the African Diaspora Development Innovation Fund. So entrepreneurs, they can actually follow it, they can see who the people are. That's usually when they move from watching on the sidelines to writing a check. So if we're looking for someone who's about to convert, what kind of pattern, we're not looking at their bank account, we're looking at whether they have a peer who went first, whether they've been given something specific that they can say yes to, and whether or not they think of themselves as someone who builds.
Thank you for that, Nicholas.
Sure.
And so we'll take a question to Serge. Where have you seen diaspora members cross that line from giving to investing? Anywhere in the broader ecosystem, not just through DiaspoCare. What actually triggered it?
Thank you for the question, Bawo. I think that the transition from giving to investing happens when, I'll say, at least three things come together, right? Three things change. The first thing is visibility. So diaspora members must understand exactly, they need to understand exactly what the capital is financing. Right? So there needs to be a clear understanding of that, and it needs to align with their values, right? Where they want to put their money. But that it needs to be absolute transparency about what is being financed. Am I financing a manufacturing plant to produce vaccines in Rwanda, for example? Or am I, because of my concerns about fake medicine, am I investing in this manufacturing plant, right, to produce generic medicines in Cameroon, for instance? So there needs to be a clear understanding of what the capital is financing. The second thing is there needs to be confidence, right, that there's a credible governance, accountability, but also a mechanism to track the capital. Right? That's an absolute requirement. We've seen situations where, in fact, we're just thinking about now, how do we convert those remittances into bonds, for instance, right? And who should be managing those bonds? So for those things really to happen, we need to have credible governance, we need to have accountability, we need to have mechanisms in place to track the capital. And I think Nicholas talked a little bit about what those fundamental requirements look like. And thirdly, there needs to be value, right? As an investor, I'm interested in a couple of things, and especially when it comes to healthcare, it needs to be measurable health outcomes. And there also needs to be a financial return, right? Or maybe both. So, the African diaspora has been investing in spite of the lack of trust, right, in family members' health. But to ask them to take the leap and turn that into investing in something else that is not necessarily a moral obligation but a financial obligation, we need to really make that leap and ensure that there are at least those three things: visibility, confidence, and value. Thank you.
Thank you, Serge. And it's interesting to see how your points align with what Nicholas had said. It's in the evidence, the compelling proposition, and then the specificity that he mentioned as well. So we'll move into the final round of questions. And here we're really looking at the practical pathways forward. And I'll start with you, Nicholas. If you had to name one structural change, not a new platform or structural change, that would make organizations like ADN more effective at converting diaspora goodwill into diaspora capital, what would it be?
Thank you, Bawo. If I had to pick one thing, and I'm curious what others think about this too, it's that I think we need to stop treating every diaspora organization's track record as a separate, isolated proof point, build a shared cumulative one instead. So right now, my belief is that every organization doing this work, ADN included, has to prove its own trustworthiness from zero. And that's with every single donor, that's every single time. That is structurally inefficient. And I think that's one of the largest things that's slowing this conversion down. So a donor who gave through one diaspora fund and had a good experience doesn't necessarily get to carry that trust anywhere. So they have to re-earn it all over again with the next organization, with the next ask. So I think that one of the structural fixes is a shared track record. So something like common reporting and outcome standard that would be across diaspora serving organizations, so that the dollar's performance is visible, it's comparable regardless of which group moved it. So I'm not talking about a platform, I'm talking about a standard. So some sort of shared metrics, some shared vetting criteria, perhaps shared public accounting of what the capital actually did. And so if our African Diaspora Innovation Fund and other entities like it, if we all reported outcomes in the same way, a donor's confidence in one might become transferable confidence into the others. And so I think that that would turn individual proof points into collective, hopefully growing body of evidence, which really is at the core of institutional trust. So I also think that part of the change is recycling capital rather than treating every grant as terminal. So structures could be designed so that some capital returns, even partially or slowly, they get redeployed. So every dollar then builds its own track record over time instead of everybody starting from scratch with every new ask. So I think that could help to shift the psychology of what I described earlier. And so instead of a donor evaluating one organization's promise, they could instead evaluate a sector's demonstrated performance. So I think that maybe doesn't address everything, but it's a great start at recognizing the difference between asking someone to trust me and then showing them a system that's already proven itself to be trustworthy.
Thank you, Nicholas. So Ambassador, I'll move to you. What is the one thing the African Union or national government should do in the next 12 to 24 months to make that shift from remittances to investment easier, not just possible?
Indeed, I think once again the health sector stands as a low-hanging fruit in this regard because of the importance it would occupy for the socioeconomic development of the continent, and of course the latest Ebola crisis and other do highlight how important it is for all of us to invest in that sector. But one thing maybe that I would put as a priority is that there are multiple studies that show that you can't really separate finance capital, what we can call finance capital, from human capital, specifically for sectors such as the health, after all, health is a very human form of sectors, a very human sector. So everything that is human capital related would be very important in this regard. Next year, we're celebrating the 15th anniversary of the Sandton, South Africa Global Africa Diaspora Summit, the only one that actually the African Union has held. And of these, and that summit established 5 legacy projects. Two of them, one of them fully is launched, the African Remittances Institute based in Nairobi, the Diaspora Finance Corporation, as we said, conceptually but not operationally, but 3 have never left the ground. 15 years. And one of them is, or actually 2 of them are either a skills database and the other one is a volunteer corps. So we're talking here about more the human capital aspect of diaspora. So if there's one thing that we can probably do for next year is to merge those 2 and to recognize that they are inseparable, the financial transfer mechanism and the diaspora health financing, the 2 need to be integrated. And studies show that this is where their effect is maximized, and that would actually bring us back to the very start that you've of the discussion that you've put us on, ably put us on, which is trust. The human capital not only contributes directly to the sector, but it also makes things visible, touchable, trustable, and hence may facilitate the finance capital as well. So that merger between diaspora health as finance and as human capital, I believe, should be our priority, at least for that initial phase.
Thank you, Ambassador. And I think very strong point that you mentioned there, linking the finance and the health capital or human capital, as you called it. It's truly important to link the 2 together. So I'll move to Serge. So the question is, from the platform side, what would you need from governments or institutions to make structured health investments feel as trustworthy as sending money straight to the family?
Thank you for that question, Bao. There are certainly not more regulations. The first thing that I would want, we need from the government, I think, is clarity. There needs to be clear rules governing investments, payments, data, and I would say data and capital movement. Right? There needs to be some very clear rule governing that. The second thing, there should be accountability, right? Transparency as a part of just transparent reporting. The transparent reporting as far as where the resources go and what they accomplish. And thirdly, there should be interoperability. What I mean by that is you can ask every innovator to build a parallel system. It would be great, at least for some of the platforms that are tradable. It would be great if the government allowed them to connect, with national priorities, health infrastructure, payment systems, right? So that they can, flow in the same direction, right? So you don't have counterproductive efforts. So clarity, clear rules governing investment. The data, for example, right? I mean, we know it's a relatively new issue, but I think it's been enhanced by AI platforms and the need for more data to improve or to launch new innovation. I think there should be very clear rules when it comes to data ownership, right? If I'm innovating based on data, I think it would be good to know with a certain amount of confidence, am I going to have access to the data that I'm building? I'm perfectly fine to share health data with government, especially anonymized health data, right? We can share that with everybody. At the end of the day, the data belongs to the patient, But, there needs to be very clear rules of engagement, not having a position today and a different position tomorrow. Payments, right? So if I'm innovating, in the direction of national health insurance, I think there should be understanding that startups are they are cash strapped. So if you repay them after 6 months, chances are they're not going to be around for a long time. So accountability again, right? The government needs to have give transparent reporting as to where the resources go and what they have actually accomplished.
Thank you, Serge. And I think we've had some very key feedback from across the three of you based on the comments. But this final question will be to all. I'm mindful that Nicholas will need to drop off. So in 60 seconds from each one of you, if this roundtable produces one concrete recommendation, what should it be? So I'll start with Ambassador. One concrete recommendation.
Is to start with a specific project with feasible geographic scale, feasible thematic scale, and get the ball rolling from there. And I once again, this is something that we really look forward together with the Africa CDC, with the African Health Catalyst Forum to work on, because we need that successful story that will actually guide our work for bigger things. That's one recommendation. Focus on one project, feasible, doable, important, and then build from it.
Great, thank you. Nicholas? Nicholas, one recommendation, one concrete recommendation, what would it be? Let me see if he's still on. Okay, Serge?
Well, I will say you got to start from existing behaviors, right? Not from hypothetical investors. Because millions of the African diaspora are already financing health every day. So the behavior is already there. But the question is really how do we make that behavior more predictable, more transparent, and investable. The other thing is in that same vein is really building, designing trust right into every transaction. And one thing that we have to keep in mind, mobilizing more capital from the diaspora is just one part of it, right? Capital mobilization, with that, one important consideration is somebody has to answer. Where should that capital go, right? To whom? Somebody should answer, how do we balance readiness versus need? Right, and also how do we know that it worked, and how do we scale successful investment? So those are right, really some of the to me some of the foundation consideration when it comes to really converting those remittances into scalable, equitable, well allocated investments. Thank you.
Thank you, Serge. And I think the comments really connected, clarity, governance. Yeah, very strong connections there. Thank you so far to our panelists. So right now we'll go into the open mic session. I mentioned earlier that we know we have some experts in the room. We'll give time for you to put in your comments, your thoughts on the conversation so far. And right after that, we will then dive into the Q&A session. The floor is open. Okay, please raise your hand if you'd like to speak. I'm just checking in the chat box to see if there are any comments on there. But please, if you'd like to speak, raise your hands and we'll unmute you, and then you can put in your comments or your thoughts on the conversations so far. Okay, I think we have someone who wants to speak. Please go ahead.
Is that me that you're asking? It's Gavin Yamey. I'm a professor at Duke University. Do you hear me okay?
Yes.
Great.
Yes, I can hear you. Please go ahead.
Thank you so much, moderator. So I was wanting to ask a little bit more about the mechanics and the machinery of capturing finance for health. Right now, we know that a lot of people are using remittances for healthcare. Nigeria, for example, we partner with the government there. But it's pretty chaotic and fragmented, and there's a risk of it kind of setting up a whole parallel system. So how could that kind of remittance financing for health logistically and realistically be used in a pooled way for countries to move along the pathway to universal health coverage? Thank you.
Thank you, Gavin. So I'll throw this question to our panelists, or is it a general thought? Given, just to be clear, was this a general thought from you, or did you want any of our panelists to answer that question?
Are there any pilots or success stories or examples of where this kind of finance has been pulled successfully, to support overarching kind of government structured healthcare on the path to UHC.
Okay, great, thank you. I'll show this out to our panelists.
I'm not aware of any success. Doesn't mean that it does not exist, but that clearly outlines a gap, right? But also an opportunity. I mean, certainly, when you look at the total healthcare financing, the total healthcare spending per capita in most African countries, I think it tends to be generally below $100 per person per year. So to be able to finance adequate health with that kind of capital, I mean, there's a long way to go. So certainly mobilizing diaspora funding to supplement, right, the universal health coverage budget of countries, I think can certainly increase that total healthcare spending per capita, right, to a more reasonable number. Maybe, I don't know, maybe it's $300, maybe it's $400. At the end of the day, it's not necessarily just, right, aspiring to be like the US, right, where it's $15,000 per person a year or more. But it's really, having a realistic number that can at least enable people to have access to the very basics, because right now, $100 per person per year doesn't buy much healthcare. So I think ramming in that direction certainly is one way. But the other thing is it also needs to come with infrastructure investment. So I'm not talking about building hospitals, but it could be those innovations that are, the right innovation that is addressing affordability, innovation that has reasonable quality, that is accessible, and really at the end of the day, right, can really elevate right, the health, not just with chronic diseases, but also spontaneous with any acute condition, infectious disease that may happen. So I think that really supplementing national health insurance plans with diaspora funding certainly there's a need, right, to increase at least the total healthcare spending per capita, but also utilizing some of those funds, right, to fund, light infrastructure projects, really, that can be scalable, that can be distributed, right, to enable more access to affordable quality healthcare.
Thank you, Serge. I think we have another comment from Asani Olumide. Please proceed with your comment. Can we please unmute Asani? Yes, we can hear you.
Okay, then. My name is Asani Olumide. I'm, speaking from Nigeria. I work, with the Ogun State Waste Management Authority. My question to the panelists is that, I just want to ask if there's any diasporal, funding contribution to the Basic Healthcare Provision Fund in Nigeria, because I know there's a fund called the Basic Healthcare, Provision Fund. I want to know if there's any, diasporal funding to the pool of funds that contributes to the Basic Healthcare, Provision Fund. That's my question to the panelists.
Okay. I'll throw it open to the panelists. Any comments, key thoughts around that? Okay. Okay. Do we have any further comments?
No, if you allow me, I would like to. All our discussion has been focused on diaspora to Africa, right? Which is important, and of course, we have this full commitment and engagement to reinforce the diaspora ties with the motherland. But allow me to maybe reverse it once. We have growing cooperation, institutional cooperation, and commitment and dedication to our global African diaspora in the Caribbean. In fact, the African Union has signed a memorandum of understanding on the, if I believe correctly, on the 24th of September 2024, between CARICOM. CARICOM is the Caribbean community, and between the African Union community. We've also established for the first time ever a dialogue between CELAC and the African Union. CELAC is the Community of Latin American and Caribbean States. It held its first round on the 21st of March this year, and we really hope to upgrade that into a higher intergovernmental level, maybe ministerial, maybe even higher. So I would say we also have a commitment, and if not an obligation, towards our diaspora around the world, and we consider the Caribbean as as an African diaspora, integral part of what we call global Africa, and of course Latin America as well. So maybe at a later point, at a later round, we can also consider how Africa as the continent can contribute and should contribute to the global health and welfare of our continent abroad, of our diaspora abroad. Maybe as a first step through the Caribbean, through Latin America, because that's where we have an institutional cooperation at the moment. So it is a two-way channel. As much as we value and we want and we need our diaspora to engage into our socioeconomic development of the continent, as much as also we as Africa have that reversal duty and obligation and attention. So that could also be another dimension we can explore together in some of our future rounds of discussion.
Okay, thank you, Ambassador. We have some more questions dropped on the chat, so I'll take the next question. This is from Anonymous. There is a lot of good talk around potential funding for health startups and entrepreneurs. However, a lot of public healthcare institutions are the foundations of healthcare in Africa and need funding. How can they ensure sustainability with all the aid cuts happening, especially because returns for investors in that sector will be slim to none? So I'll throw this out to our panelist, Serge or Ambassador. I want to take this question.
Yeah, this is definitely. I mean, thank you for that question, because that's a very, very fundamental question. What we have observed as private sector, with the ambition to make affordable quality healthcare available, not just to diaspora members, who are family members, right, who can support that, but really to just anybody who needs access to more healthcare. So we've actually started thinking about, you need sometimes to sow the seed yourself. When something is not there that you think is a key piece of the puzzle, you need to take the risk and do it yourself. One of the recent pivots that DiaspoCare did was to partner to deploy mobile diagnostic kiosks, right? So those are diagnostic kiosks that can be placed anywhere, not just in hospitals, but also in pharmacies, in rural areas, and so forth and so on. So we can screen over 60 plus actually health parameters, and you will get the results in less than 10 minutes, right? So it comes with a kiosk, with a telehealth screen that enables you to share the results with a doctor, for example, or a hospital, if the kiosk is in rural area. And then you can receive a prescription if the kiosk is in a pharmacy, for instance. So the idea being, how do I enable somebody who is in a rural area to have access to diagnostics capabilities as quickly as possible, to actually exchange with a reference hospital, right, about the results, and to receive a prescription. Those sorts of innovations, we actually are piloting them first with public facilities. Just because we recognize that it addresses a lot of challenges. First of all, the patient journey. Today, if you're looking for primary healthcare in Africa, you have to think about at least 2 days. You go to the hospital, you wait for hours. Then you are sent to a lab, because really less than 20% of primary healthcare facilities generally have a diagnostic lab, an adequate diagnostic lab. So likely you will be sent to a lab that is not located in the facility. So you go there, you give your samples, and then you wait for a day or two to get the samples. Then you come back to the hospitals with your results, right, to get the consultation. So collapsing that into maybe a 20 or 30 minutes, right, session where you come in, you get screened, right, you have your results available, you can share with the doctor and, you know, get the prescription and then walk out if you are in a pharmacy. So this sort of innovation, really piloting them with public facilities enable, right, to reduce the wait time that people experience when they come to hospitals, not to have to go to another lab, to another facility to get your results, but also actually, you know, just thinking about how hard it is when you're sick and then you have to go through this type of journey, right? Interestingly, most people actually don't even go to hospital. I mean, not most, a lot of people actually go straight to pharmacy because they don't want to wait for 4 hours. And they hope that the pharmacist will prescribe something that will make them feel better, right? So that's really, so to come back really full circle to the question, the reason why we are piloting these innovations with public facilities is because more than 50-60% of population goes to public facility for healthcare. And if you can make a difference there, you have the possibility of scaling. You're not going to make money on margin as a private business, but at least, you know, the government will give you through those facility access to patients, right? And the patient acquisition, as any healthcare innovator knows, is probably one of the most expensive things, right? In your cost structure. So acquiring patients is expensive. So if you partner with governments, with health facilities, at least you have access to patients. You're not going to charge patients a lot of money, but at least you get the volume, you get the impact, you know, you get the legitimacy from the government. And, you know, at the end of the day, I think you make a step towards the right direction of enabling access to healthcare.
Thank you, Serge. And we have the next question from Yannick. Besides remittances or directly, passively investing money into specific funds, investing could also be active by actively contributing in the implementation of solutions. For example, research, AI tech tool development that addresses issues within Africa. How does Africa CDC help with this? So please confirm if that question is clear.
It is clear.
Okay.
This is a very good question, a very important question as well. And we tend to focus overly on the money, on the remittance, the financial remittances, but we tend to forget that there's humongous human capital that is available in the diaspora and even locally in the intra-Africa diaspora. So when you think about the number of scientists, the number of doctors, the number of nurses, the number of radiologists, the number of specialists that are available in the diaspora, you know, that is even more important in terms of scale and in terms of return, because it appreciates. I mean, human capital appreciates a lot faster than just the money, right? So research and development, for instance, I mean, I read a study not long ago that there are at least 20,000 scientists, African scientists, right, in some of the finest research and development institutions in Europe and in the United States and Canada. I just think about how do you bring that knowledge back into Africa? I mean, I really appreciate those sorts of opportunities to enhance innovation and kind of impact that they can have. I mean, I spent most of my life in technology licensing and technology commercialization, so I can really appreciate the, you know, how you can, right, enhance, you know, you can create a lab and a research and development lab and encourage all those, I would say, those heroes, you know, graduate students in Africa who have to be in a lab and who have to improvise and who have to conduct research with very few instrumentations and count on really, really minuscule grants to do their work. If they get the opportunity to do a postdoc and exchange, right, with a research and development lab in the United States, in Canada, and Europe, right, if they can have, right, joint research projects, right, and so I mean, those sorts of initiatives I appreciate considerably, and I think that we tend to overlook and only focus on the money part of it, but that is absolutely a critical capability that we need to double click on.
Thank you. Thank you for that, Serge. And I think just to add that's the work that the EWG is also looking at, because they were capturing all the different stakeholders in the ecosystem, right? That is really critical to really just the impact, right? And moving the needle forward. So thank you for that. And I think we have one last question. In the context, this is from Anonymous, in the context where many local and diaspora-led health initiatives already exist, how do we better capture, connect, and scale entrepreneurship and startups?
I think one of the models that we don't need to recreate the wheel there. I think that we have examples of very successful innovation studio. We have incubators. We have more and more of those actually that are being seeded into Africa, across Africa, and that are really, really absolutely needed. Because I mean, it's one thing to have a brilliant idea, but you know, the statistics are right daunting for any entrepreneur. You know that 75% of ventures fail within the next couple of years. So being able to properly incubate right those innovations and providing them with the right resources, like understanding how to put together like a business model, a business plan, and understanding what are the capabilities that you need. How do you build a value proposition, and how you test your idea. How do you test your idea and iterate right very quickly, cheaply, without necessarily needing a lot of money. How do you do it efficiently and move to this product problem solution fit and ultimately, hopefully, to a product market fit. So I think those incubators are absolutely needed. They are absolutely needed to move the dial. One of the things that we also observe is, I mean, with the lack of employment opportunity in many African countries, people realize that entrepreneurship is probably the ticket out of poverty, right? Or at least a way to express their talent. So having those incubators really gives them a channel, right, and a way to connect with what is available out there, because if we don't, right, unfortunately, those ideas never get out of their heads and they never really see the light of the day. The other thing that I will add is it is extremely important to encourage local entrepreneurs because they live the realities of Africa. They understand those problems probably better than anybody else. Diaspora members need them, right? We need to partner with with innovators in Africa, like to have a better reading, a timely reading of what the problems are. We need to partner with them to test the solutions locally, and for all kinds of good reasons why we should be doing that. We should be doing more of that.
Thank you, Serge. And I think we're at the end. Ambassador, any final thoughts from you before we go into the closing?
No, I would maybe end by saying that as much as the health sector is indeed the most relevant one, and that's why we're very happy that we're starting this partnership, as much as there are also lessons to be learned from other sectors. So it will be useful to situate our engagement on the health sector and diaspora within the more global, comprehensive perspective of engaging the diaspora in general for the socioeconomic development of the continent. And that's why we are very happy to be with you here. And we would be also happy to import, if there are any other lessons to be learned from other sectors. I would also say that it is important to have a continental perspective because that harmonizes the policies, cross-fertilizes the determinants of this engagement, but also the RECs, the regional economic communities, have an important role in this regard. I would particularly highlight a new initiative that we are undertaking with COMESA. COMESA is the Common Market for Eastern and Southern Africa for investment corridors. They have not particularly tackled the health sector, but we'll be happy to bring your experience onto them, and I'm sure they will be also finding some opportunities in this regard. Last point is that diaspora in financing is important, and it's becoming a most crucial constituent of development finance, but it's not a panacea. It's not a panacea. It is not a solution for everything. And we have to also look at this, the African Union is actually doing, and within the other forms and channels of finance, especially with the new geopolitical change that we have spoken about and the decreasing size and maybe even role of ODA. So it's not a panacea. We need to, again, to situate it within the bigger picture of domestic resource mobilization and development finance in general. So that's what afterthought that I will also leave myself and the whole audience with.
Thank you very much, Ambassador. So just to bring the conversation to a close, and I would just share some general thoughts and a summary from the conversation. I think we talked about the need for proof, a credible personal translator, really to move the needle forward. We talked about the importance of starting small. We talked also about the need to build trust into the product that we're putting out there, and how specificity is also very important to translate the interest into the commitments. We also looked at the importance of shared track records and how this ties to visibility and evidence, and then also the need to recycle the capital within the system. And then lastly, we talked about the need for more clarity, governance, especially around data and ownership. So with that, I want to start by thanking our distinguished panelists, Ambassador Amir, Dr. Serge-Alain, and we have Mr. Nicholas, who has dropped off to handle some other business. Thank you so much for your time. Thank you for all the insights. Thank you, big thank you to all the to those online who have joined and also invested their time. A reminder that this is the first of 3 roundtables from this series, From Potential to Power. We have the next one coming up on the 26th of September, 2026. So this is happening every last Thursday of the month. And we have 2 more roundtables to go. And the next one, which should already be on your calendar, is on the 26th of September, 2026. Thank you once again to our panelists, our partners, and to everyone who's joining. I'll hand over now to Edward for the final closing. Edward, over to you.
Thank you very much to the distinguished panel that we have today, and of course to our erudite moderator. Thank you so very much. We look forward, thank you community, to everyone who has been a part of today's meeting, and for your active engagement with the Africa Health Catalyst Forum and the series co-hosted with Africa CDC over time. Please join us last Thursday of September, last Thursday of October, and we'll be glad to continue and push forward this this conversation. As you know, with Africa Health Catalyst Forum, our dialogues are not just mere talk. We want to talk so that we can have action that follows. And we're all looking forward to work together with you all to move that action for the health of the African continent. Thank you, everyone. That will be all for today. Bye now. Thank you.
Thank you so much.
Thank you very much. Goodbye.
Thank you all. Bye.